Now we're gonna go over some of the passive accessory motions that are available in the knee. And as a reminder, passive accessory or accessory motions in general need to be full in order for your patient to have full physiologic motion, meaning in the knee anyway, extension and flexion with some of the internal external rotation. And accessory motion is the roll, spin, and slide, or also known as glide. And with these, we're gonna start with the patellofemoral. And the way that you do these, and there's lots of different ones, the main ones that I'm gonna show you are gonna be really similar to the apprehension test. But when people have superior, inferior patellar tendon issues, these are some of the tests that you would really do the most. And so what you're going to do in general is just put your fingers to do a lateral glide, put your thumbs on the medial aspect of their patella, or if you're standing on the same side, put your index fingers, and you're just going to laterally, and you guys should be able to see how his patella, it's kind of bowing over the side. You can see that it's coming, and you are assessing end feel, asking him if he has any pain, and looking for general joint play. And then to do the medial glide, you're just doing the opposite, and you're pushing in the opposite direction. So your fingers should be on the lateral border of the patella, and then just straight translating the patella medially, and again looking at joint play and glide and pain and everything else. And these are really great to do after people have knee surgeries, or if they have tendonitis in their suprapatellar and infrapatellar tendons. You can also do superior and inferior glide. So inferior is just putting your fingers on the base, which, remember, the base, it's opposite. The base is the most superior part, and the apex is the inferior part. So the inferior glide would be mobilizing them inferiorly, and the superior glide would be closer to the apex and then mobilizing them superiorly. We also have glides of the tibiofemoral joint or the femoral tibial joint, depending upon who you're talking to. I'm only going to cover a couple here. As a reminder, the anterior translation and the posterior translation are the same as the Lockmans and the reverse Lockmans. And since we go over those in special tests, I'm not going to really bother with them here. The ones that I am going to talk about are going to be the medial glide and the lateral glide. These are not the same as doing varus and valgus assessments. With these, you are actually taking the tibia and going straight, either medially or laterally. There should not be any kind of rocking or rotation of those medial and lateral structures. So to do the medial translation or the medial glide, you can either have them down on the table, or you can actually pick their leg up, but you need their knee to flex around 25 degrees. To do the medial glide, what you're going to do is you're going to stabilize the medial femur, and then you're going to put your other hand on the lateral tibia, hold them in place, and then you are going to take their tibia and go straight to the inside, medially straight in. And I'm going to tell you right now, they should not move. If all of their structures on the medial side, so their MCL and the retinaculum and all of their muscles are intact, you shouldn't really feel motion, at most just a little bit. If it is moving, you're going to be looking for damage to those medial structures. So the MCL, the medial capsule, the retinaculum, these medial muscles, so potentially the hamstrings and your adductor muscles. To do the lateral translation, same thing, a little bit of flexion. You're going to have your stabilization hand on the distal lateral femur and your mobilization hand on the proximal medial tibia. Ask them to really relax, and then just straight lateral translation. You are not applying varus stress. Varus stress is the opening. What we're doing is lateral translation. Again, you're going to feel a little bit of motion, but they shouldn't be opening up or anything. If you do know a great deal of motion, again, we're looking at damage maybe to the LCL, to the IT band, potentially to the lateralis, not typically though, to the capsule, and that kind of stuff laterally. So, and also when we're doing these tests, if they have damage to the ACL and PCL, those can also cause issues. But remember, those two tendon or ligaments are really more important when we're talking about the anterior and posterior translation. Then the last one we're going to talk about is the distraction test. If you'll slide down. So the distraction test looks again at general knee mobility, and they're just going to be very relaxed. And this test is not very difficult for you or for your patient. All you're gonna do is have them in a little bit of flexion, and sometimes I just hold their lower leg so it's not flopping around with my knees, so that way I don't have to try to stabilize it so much. And then try to get their leg in neutral so it's not fully externally rotated or internally rotated. And then you're going to grab or grasp their proximal tibia and then just apply a straight distraction force. So I am holding on to their bone and I am pulling down straight through their tibia. And so I'm applying traction or distraction to their joint along this line. And so I'm stretching out all of these lateral structures as well as the internal structure. So basically all 4 major ligaments are getting stretched, as well as our infrapatellar tendon is gonna feel it. So if we have stuff going on, in addition to that, remember the hamstring muscles are going to span this joint as well as the medial and lateral gastroc heads. So if this causes them discomfort, you're gonna wanna find out where that pain is and how bad that pain is. In addition to that, certainly looking at their mechanism. If you think that they dislocated something, this is not what we're doing ever. This is not an assessment that you would wanna do, especially if it's for their patella or for their tibiofemoral joint, because 1, it's gonna be already super messed up, and 2, your patient is never going to trust you again if you start doing these kinds of maneuvers on them, especially if they're brand new acute injuries.